Wonderful. Thank you so much. And thanks everybody for being here and being a part of this for me and for each one of us. This is such a journey for the ones who are beginning and the ones who are finishing. So again, my name is Christi Denton, and I am here today to present the final project outcomes on my stress inoculation training program. First thing I want to do is thank my committee members. First, Dr. Joni Jackson. I went through this process with two very good friends who all three of us completed this, or we'll complete this at the same time, but they were at other universities. And what both of them said was during the course of this project that they completely lost their voice, that what they found at the end did not reflect them at all. On top of championing me and assisting me along the way, Dr. Jackson made sure that my voice was what came through in this project, and that is so valuable to me. So I thank her for that. And Yvonne Jones, my community member, is the definition of what a community member should be. With every step of the way, she texted and emailed and wrote and called and said, what do we, not you, but what do we need to do to make this happen? And I cannot thank the two of them enough for this. So last year I sat here and I told you about my journey as a resuscitationist and an intensivist, and how stress inoculation had become so important to my practice and something that I wanted to share with others. So today I join you a year later to talk about the journey that this project has taken. So I want to review first a little bit about the psychology of stress, what we know about stress and resuscitation. First, emotional arousal, that immediate anxiety that we feel when we're coming into a high stress resuscitation situation, that leads to an increased cortisol and noradrenaline production within the body. That hormone and that chemical response within the body is what wakens our brain. It increases lateral and prefrontal metabolism and springs us into action. It's what makes us bright, thoughtful, and ready for the challenge. But what we know is that stress has a point of diminishing returns. Yerkes and Dodson were some of the first to study this when they were studying mice in the early 1900s. They had tasked mice with a maze, and what they found was that by applying small electrical shocks to the feet of the mice and producing some stress in those mice, that they actually performed better. So they turned up the electricity, thusly turning up the stress on the mice who were completing a task, and found their performance improved. But when they tried this a third time, when the mice became so stressed, their performance began to fall apart. They couldn't remember the things that they should do. They had reached a point where the stress had overtaken them. What we know is that this occurs in humans as well, that when stress becomes too much, when we're no longer able to handle the physiological consequences of, we begin to have impairment in our performances. We have divided attention, poor memory, and a poor decision making. I'm not sure why I'm moving so slowly. All right. So the purpose of this study, in all the things that I read in regards to stress inoculation training, one of the most profound things was actually an interview that was done with Mike Tyson before a fight in the early 90s. An interviewer for the San Bernardino Sun spoke with Mike Tyson and said, we interviewed your opponent in a match that's coming up, and he says that he's reviewed all of your tapes. He knows how you operate. He knows what you do. He knows exactly how to defeat you. What do you have to say about that? Mike Tyson just laughed and said, yeah, everybody has a plan until they're punched in the face. This spoke to me so much because the training that we do in hospitals is exactly this. We train people to do procedures. We train people in ACLS, in high pressure situations without the pressure. We teach them the skills of boxing, but we don't teach them what to do when they're punched in the face. So the purpose of this study is to address that gap in stress response and the mitigation of that physiological process. Utilizing the stress inoculation training model, the plan was to gather qualitative and quantitative data from nurses and respiratory therapists regarding their personal experiences in previous resuscitation and the physiological process of stress that they've experienced. The PICO question was, and respiratory therapists and nurses tasked with a primary response to an unstable patient requiring endotracheal intubation, does a stress inoculation training program, as compared to a standard rapid response training, increase the knowledge of stress inoculation training interventions, stabilize cortisol levels, decrease perceived stress, and increase self-appraised technical skill in participants over a 6-month period? No idea why I'm lagging. Project details. So the study had a total of 26 participants. That was 10 respiratory therapists and 16 registered nurses. Each of those went through a 90-minute pre-brief and training session. It was an introduction to the performance enhancing psychological skills methodology and a chance for me to understand their previous experience in resuscitation. They came back after a 2-month preparation period where they took those skills and placed them into practice. Then individual interviews were conducted in addition to the survey, as well as cortisol sampling. So initially, our quantitative data, this was taken from those pre and post test surveys, the ones that were done in the initial group interviews as well as the individual interviews afterwards. Those questions included information regarding stress at the initiation of resuscitation. When you receive that first call into a resuscitation, how do you feel? What is your anxiety level? What physiological symptoms are you aware that you experience when you're under increased stress and resuscitation? What is your procedural confidence? Not just in the procedures that you perform, but in that high pressure situation. And what is your ability to regulate that stress response? Pertinent findings from the qualitative data. This was in comparison of the pre and post survey test results at a significance of 0.05. The first one was anxiety at call. This was a Likert scale from 0 to 5. On our initial pre-training survey, participants stated just above 3 that they were moderately anxious at that initial call, that before even arriving into the room to see what was going on, when they knew that they were going to be called in, that they rose to a moderate anxiety level. In our post-training survey, we saw that that anxiety fell to just above 2.5, which was a significant difference in the anxiety that participants felt before they entered a room. The second was feelings of failure, which I thought was something that was so important to see in our participants. The question was, when you have physiological symptoms that impair your performance, do you feel like you failed in a resuscitation? And in our initial response, we saw that an initial response of around 3, that we had a moderate response of feelings of failure when we had difficulty with physiology in difficult situations. In our post-training survey, we saw that drop to just under 2.5, which was incredible to see people feeling better about their performance, even when they had stress, when they exhibited these physiological symptoms. And the last one I feel like was the most important, and that was, do you have techniques to control that physiology now that we recognize it? I was surprised to see how many people felt like before the training that they had a set of techniques going into this to calm their physiological response. But certainly afterwards, with greater than 4, most people felt like their toolkit had new things in it to assist their physiology in resuscitation. Even more important than the quantitative findings, I feel like the qualitative data in this was exceptionally rich. The group interviews that were done before discussed the experience of resuscitation and the physiology that they experienced. 4 themes that came out of those interviews were as follows. My body is not under my control. People discussed feeling shaky, an inability to hear clearly in a room, to not be able to make decisions like they normally would. They talked about the environment of resuscitation being unpredictable, that your role in one resuscitation may not be your role in another resuscitation. Something that you feel comfortable with may not be the role that you're assigned, and you may not know your team members going in. Roles are unpredictable, along with the second theme. I'm not sure who I need to be when I come into this room, and that's unnerving to people. and that perceived judgment makes participants increasingly nervous. When they do feel like they have failed at something, when they feel their physiology fail them, they feel judged by the other people in that room. In post-training qualitative data, the themes that emerged were, I have an understanding of my personal response to stress. People talked about feeling their heart rate increase, their breathing increase, that they now knew that this was a physiological response within their body to the stress that they were experiencing, and that it was something that they had control over. And that was their second theme, that they had developed real techniques for control of these responses. The things that hinder our performance in resuscitation, every single participant said that they had developed a new technique for control over those symptoms. Changing environment makes it more difficult. This was something that was repeated pre and post, that even with new techniques, that a changing environment, not knowing where this was going to happen or with whom, still made that more difficult. And each participant that I interviewed said that they had created a change in their practice, whether it be the techniques that they used to control their stress or how they taught new people that were coming in, that they were charged with teaching things in resuscitation, that it changed their practice and how they led others. The other thing that I wanted to briefly discuss was state trait anxiety scores. If you're unfamiliar with this test, it is given to people in two sections. One is to measure state anxiety, one trait anxiety. State anxiety is how we feel right now, how I feel before I come into a presentation. Do I feel nervous or jittery? The trait anxiety measures more who we are as a person, how anxious we are at baseline in our everyday lives. So while state trait anxiety scores did not play out as any significant difference with training, what I did see was that we did have a change. And all 26 of the participants that were a part of the study were active full-time COVID providers. And what we saw was between our pre and post state trait anxiety scores, that initially we had a mean score of 20.9. Rising to just over 21. The people that were part of this project that participated in this had an incredible amount of stress in their lives as part of a global pandemic. And I think that the results might have even been more profound if our baseline had been different during this time. COVID certainly put a strain on all of our projects. This was no different, but I think it's really telling as to what these people have been through. So how does this project help to close the gap? Well, performance enhancing psychological schools is a tool that's been proposed to help modulate the physiological stress of resuscitation. This project demonstrated the tool's effectiveness in reducing anxiety, decreasing self-blame, and increasing techniques to deal with physiologically unpleasant symptoms. The theory of unpleasant symptoms is the theory that this project was based upon, about how we can teach patients and providers to mitigate the unpleasant symptoms that come with stress. Participants specifically noted the use of tactical breathing and the use of a focus word as the techniques as part of the PEPS toolkit that was the most helpful to them. So really, I think that moving forward with this project is answering a call to mental health. This project was completed at Erlanger Hospital, and that's where I would like to continue my mission as they are familiar with the project there. I want to add this into the onboarding of new nurses and respiratory therapists. We've seen that this toolkit helps to increase resiliency in providers to make them feel better about their practice and themselves, that it helps them to understand what to do when they're punched in the face. And we need to offer that to new employees. I also want to see this included in medical resident education. While we talk about nurses and respiratory therapists during the project, we know that the next group that we need to reach out to is our medical residents who are beginning their careers as well. And lastly, a provision to current employees. As we've seen, especially during the last 2 years, Current employees often get overlooked as we bring in new people, as we attempt to recruit, but not enough is done for the people with experience, the ones that are considered experts in the field. We can still make those people more resilient, make them feel better about their practice, and make them more comfortable. And we should find a way to reach our current employees as well. Given the success of this and the addition to onboarding, particularly of new RNs, I'd like to see this expanded to other area hospitals. This is something that we should share widely because it impacts the health, particularly the mental health of our providers. Moving forward with dissemination, Mike Loria is the physician that was the developer of PEPs. I reached out to him early in the project to let him know that this was going on and what I had planned on doing. So the first thing that I want to do is send everything back to him and hopefully collaborate moving forward on how we can continue to improve on the PEPs toolkit and make this a part of more medical education. And secondly, reaching out to publication, particularly in a respiratory therapy journal where I think that this information hasn't been provided. I want to see them highlighted in this way. How did the DNP essentials specifically impact my project? Well, the first is essential one, and that's the scientific underpinnings of practice, the wholeness or health of human beings, recognizing that they're in continuous interaction with the environment. That is the entire purpose of the project, is for people to understand how they're interacting with their environment and how their environment plays upon their skills, their mental health, and their practice. Essential three, clinical scholarship and analytical methods to design, direct, and evaluate quality improvement to promote safe, timely, effective, efficient, equitable, and patient-centered care. Again, that's what this entire project has been about. Design and direct and evaluate a quality improvement measure to improve our providers and to thusly improve patient care. I'm happy to take any questions that you have.
Thank you so much, Christi. I'm going to open it up to Dr. Jackson and to Ms. Jones.
I just wanted to concur with Christi that Yvonne was probably the quintessential community committee member. And if anyone is thinking about a respiratory linked project in the future, she has agreed that she will serve on future committees. So, and I will reiterate what Dr. Dupre said. Without our community members in the trenches with our students, we would have no projects. So, congratulations to Christi on a fine presentation and a wonderful implementation of your project. We look forward to what the future holds for you.
Yes, thank you, Dr. Jackson. And yes, if anybody would like help with a respiratory project, I'd be happy to help. Christi, thank you for shedding light on our trials and tribulations over the last 2 years. It's definitely been a challenge to watch staff and to work alongside the staff be thrown into a worldwide pandemic and see the benefits of the tools you're giving them and how to improve our onboarding process is something that I'm always striving to do as a respiratory educator. And congratulations on a project well done and well-deserved for our community.
Thank you guys again so much. I didn't mention during that, but I did cortisol sampling with this as well. And the Baylor School graciously agreed to help me run that with their equipment. And then they had equipment failure. And because of supply chain issues, we have been waiting on them to get a part in. So the cortisol sampling piece of this still waits, but it provided one of my best laughs in that I was at the hospital one night with one of the respiratory therapists who was doing this with me. And she said, "Oh, I'm here. I know you need me to spit in a tube tonight." I said, "Yes, please." And she said, at 3 a.m., outside of a crashing patient room, in a COVID unit, in a pandemic, yeah, these cortisol levels are going to be impressive. So it's the last piece of data that I cannot wait to add into this to demonstrate exactly how brutalized we have been.
Thank you, Christi. Are there other questions for Christi?
But thank you for adding that. That was going to be my question. I had a little question mark on my notepad as to what happened there, but understandable for sure.
My freezer is full of a box of spit. Just waiting on the plate turner to get fixed at Baylor. So
How long do they keep? Do you know?
as long as they're frozen for as long as I need them to be.
Perfect.
As long as you inhibit bacterial growth, your sample is safe. So just a box of spit in my freezer. Yes. In the name of research.
And kudos to Dr. Joanne Romani from the graduate school. She graciously found the funds within her budget to purchase the cortisol test kits. So thanks to her, we were able to fit that component into Christi's project.
Yes. Thank you all so much.
Thank you so much, Christi. We are